evening. I'm Dr. Higgs, the medical director at the Houston Methodist St. John Hospital Concussion Center. We're here tonight to give a brief talk on concussions, basic overview of them, how we treat them, what signs and symptoms are, what we need to do to have a clearance on them as well. What are your signs and symptoms? What does a patient come in with? Obviously, the big hit on the football field is where we always look at. Loss of consciousness. They often stand up. Sometimes they vomit or they stagger off the field. When they're questioned, they don't know where they are. They may have changes in vision. Their ears may ring. Maybe a plethora of signs and symptoms. They may be very emotional. Some people cry a lot. You may have others that just become angry, injure their hands by punching benches and water coolers. There may be multiple other things going on there. Again, the big thing that we often see too with these is we talk to the injured athlete, and when that occurs, we give them a response, ask them questions, and they continue to either ask the same questions we're asking or ask the very same questions to us over and over again, and what the quarter is, what day is it, what happened, and they just don't remember. Emergency room signs are what we always worry about. Typically there's a big differential. We worry about neck injuries, we worry about brain bleeds and all the various types, and so really we look for focal neurologic deficits, which means, are they vomiting? Does the patient become lethargic? Are they just sleepy and unarousable? If they have neurologic signs, they may have tingling, they may have changes in their neurologic examination, loss of reflexes, weakness on one side of the body, one arm, that sort of thing. They may have one dilated pupil, the other pupil may not be dilated. Those are things that we're really looking for to get them to the ER as quick as possible for imaging there. So what do we do to treat? So what I like to call relative cognitive rest, and so we let the brain take a vacation. We let it relax from any further physical injury, meaning jogging, running, jumping on trampolines, anything else that may hurt the brain, but we also give it a relaxation from working and processing information and data. That often reading, concentrating in school, text messaging is often what we see, the teenager's third hand that we often have there. Typically in the first 48 hours to 72 hours, we want them not to take anti-inflammatories. Tylenol is okay because it doesn't change or increase the risk of bleeding, but if there were to be a subdural or subarachnoid bleed, we wouldn't want to take in anti-inflammatories because it may worsen those symptoms, especially with aspirin as a no-no. Decrease caffeine and really just relax. Sleep as much as you possibly can. The more you sleep, the more your brain's relaxing, and then just stay away from things and activities that increase your symptoms. So how do we treat it? Really, there's multiple ways to treat. So we rest the brain, but rest doesn't always help everyone. So how else can we help these patients? Normally with these, if you've had a concussion, or the patient has had a concussion, we often see that they also have a upper neck or neck and mid-back sprain, strain, or whiplash. In those patients, the neck, the muscles around the neck, and the joints may also be causing pain. They also may be referring pain to the head. They may also cause changes in their balance and make them feel dizzy as well. So there's a multi-specialty kind of approach that we take. Physical therapy for all the physical and mechanical type things like in the neck and the upper back. We also use for cognitive deficits and problems, we use our speech and memory clinic to try to help with different techniques there. Depending on which part of the brain is injured, we also may have vestibular issues, and the inner ear may play a role in that, and so we use vestibular therapists to help us with that. Medications, we try to minimize them, but we use them as we need to. We can help with restrictions and accommodations at school, and then the big thing is we keep them out of exertion. So once we're hurt, how long does it take? What goes on? The Zurich guidelines give us fairly good guidelines to get us there. What we really want to do is you have to be cleared both from a cognitive, you have to be tested no symptoms during cognitive challenges or physical exertion. So we have to stress our brain, and we also have to stress our bodies before we can return to full play. You have to be asymptomatic, you have to be off all medicines that you may be on, and you have to be able to return to a full day of school and a graded exertional protocol to get back to your sport. Return to play protocol, there's typically 5 or 6 stages depending on where you go. A lot of people use stage 1 as being asymptomatic completely for 24-hour, minimum of 24 hours. Stage 1 then goes into light, it's just a progressive increase in your activity and exertion. It ends in a full practice or scrimmage in whatever that sport may be. It can't be a staged full contact practice. We want them to actually be interacting like they are with all the other teammates in their sport and during the practice. So if it's often a football game, we really want them, we don't want full contact practice, the last stage, stage 5, to essentially be the day before the game because it's typically a walkthrough. We don't want a stage, we want them to actually go through everything there. How do we prevent concussions? Well, multiple things. We really want to stop further injury once we have the concussion, number 1. We want to make sure we're physically fit. Football players need to have strong necks. We need to work on balance for dancers. We need to work on techniques if we're tumblers or cheerleaders in a padded arena instead of hard gymnasium floor at times, just to make sure that when we're a base and cheer, we don't drop our other cheerleaders. When we're working on taking charges in basketball, that we learn how to do it in a controlled manner before we fall and hit the back of our head on a hardwood floor. Behavior modification is always there too. We don't want to bang our heads against lockers, against doors, things like that because we're angry and raging as well. So equipment, again as well, proper fit is the most important thing. The issue always comes up with helmets, and so do helmets prevent concussions? There's a lot of debate on that in the literature. We do know that the fancy helmets don't necessarily prevent concussions, but we know a poor fitting helmet can increase your chances for a concussion. Coaching and teaching, again, a good example is the charges with in basketball, learning how to do it in a controlled manner and in a padded floor. And then rule changes and compliance have also helped us. Really, no further contact with the crown of the helmet or helmet-to-helmet contact on a receiver trying to catch a ball over the middle of the field. Any questions?
Do the soccer bands around their heads, do they help? They have those protective pads that they can get?
Yeah, they're often a question in the clinic, and I get that from almost every injured, mostly female soccer players that we see. The answer is there's no data on it. So it's much like a football helmet, that if you have something that's secure and going to help you, it is a pad. Really, it's more about technique with heading the ball, being prepared, and heading the ball properly.
What about mouthpieces?
They don't prevent concussions. They prevent a lot of other injuries. But again, the biggest thing is going to be a well-fitted mouthpiece. But not much data on whether or not they actually truly prevent concussion.
Symptoms for dementia.
So how do you know the difference?
How do you know the difference?
And
Well, typically with concussion, there's going to be an injury, number 1. Dementia is going to be, there are various types of dementia. So it's usually more slow onset in different age group. However, let's say you're 55, 65-year-old person who comes in who's been in an automobile accident, it can muddy the water some because you could have early dementia in addition to a concussion. So there's different testing that we use that can also help delineate what memory loss may be or what many of the symptoms are coming from.
I'm Dr. Jack Fulkman. Tonight I'm going to talk about the post-concussion in chiropractors, when and why sports medicine chiropractors should be involved in certain cases of concussion. So what is a sports chiropractor? It's a certification by the National Board of American Chiropractic Sports practitioners, and you take 120 postgraduate hours of classes, which used to take you a year or two, and then pass their national board, and then maintain at least 12 hours on top of your other CEU requirements yearly to maintain that certification every year. And you have to maintain an active membership. So it's not, a weekend seminar, it's a course over the year of really diving into the sports aspects of it. Richard Cantu is kind of the man as far as medical. He helped develop the impact, and he actually just gave a talk last month to the Football Chiropractic Society for the professional chiropractors who work with the sports teams in the NFL, and he talked about the using chiropractors to help relieve the secondary complaints, the neck pain, the fogginess, the headaches, to help get the athletes back to sport faster and more cognitive than they were before. So what is concussion? As Dr. Higgs talked about, it's a mild traumatic brain injury. When the head is hit or is hit by a moving object. And if you think about it this way, there's no way, it's really impossible to have a concussion without involving the neck and spine. So it's hard to have a concussion without injuring the neck. And that's where we kind of shine as far as my profession. We see patients in here, not just sports, but we see or our high school athletes. We see dancers. We see adult professional engineers that go and wreck their mountain bike or go wreck their road bike and they get concussions, or they get car accidents. We see quite a bit of those. So it's not just young people and high school athletes we're talking about. It's really impacts the whole population. Slip and falls, elderly slip and falls, and they end up hitting their head as well. So, and they describe, and we see them after they've been evaluated usually. They're not getting better, so what else can we do? So they get sent to the chiropractor. They're foggy, they're dizzy, they're headaches, but they're returning to work, but they're not able to concentrate. So you get a post-concussive syndrome, after effects, headaches, visual disturbances, irritability, dizziness, lightheadedness, fogginess. Could take weeks, months, or years. But also, you have neck, shoulder pain, tingling, loss of range of motion, muscle spasm, and just the general feeling of I'm not quite right. Consulting chiropractors for post-concussion syndrome, they've already been diagnosed, they've had the impact, or they've had the CT x-rays, they've gone through the cognitive therapy, they've worked up at the concussion center or emergency room. They've not been, or they haven't been diagnosed. We just came off the street and I had this car accident. We had a girl walk in today and she has a big noggin on her head, black and blue, from 2 days ago. She definitely has a concussion. Just by looking at her and talking to her, we know that. Or they're undergoing current treatment with the athletic training or physical therapy. And those are the kind of patients we see with post-concussion syndrome, but they're not responding, which was brings them here. Our evaluation, of course, we look at what has been done and what hasn't been done. We check their visual tracking. We do the tongue deviation test, and the reason why we do this test, we'll go into the anatomy later, but if it's cranial nerve 11, we can actually see a deviation in the tongue slightly if you just stick the tongue out. And if you have that, you have a cranial nerve problem. We always think as chiropractors, spinal nerve, cranial nerve 11, and we'll go into that. The vestibulo-ocular reflex test, I don't know if you guys use this, but this is a suggested test where you rapidly back and forth and you grade them 1 to 5, whereas 5 they can't do it, when they can, and we can figure that out. And then spinal accessory nerve tests. So visual tracking, we take the pencil, we go in front of the eyes and make sure that all the fields of gaze are working properly. Headaches and irritability or nystagmus during this test indicates that they're having post-concussive problems. The VOR is a pretty strenuous test, but you just have the patient shake their head as fast as they can without pain. And grade 1 involves aggravation of the symptoms. with just slow rotations. Grade 5, they're going as fast as they can, and it's not a problem. So, with somebody who's really concussed, you don't really want to do this. So, and then the tongue deviation test, you have them stick it out and move left to right, and if you see a loss of movement, you could have some encroachment on that cranial nerve 11, which exits the base of the skull, wraps around the front, and inserts into the SCM and trapezius muscle. What we're talking about here is this nerve actually exits here. Some of the branches go over to the tongue, and the rest go to insert and innervate these muscles here. Depending on where the lesion or the impingement could be, depends on whether you have tongue involvement or muscle involvement or both. So there actually is a structural component here, that physical component we're talking about, that what we're able to influence with our treatments. This is a demonstration of loss of tone of this muscle compared to this side, because this nerve has been damaged. Our intervention, of course, we do use traction. Many physical therapy clinics don't even have traction because it's a modality that is not well reimbursed, but we know it works. So we use that here, and many chiropractic clinics have it. Soft tissue manipulation, soft tissue with Graston or ART or some kind of physical intervention on the soft tissues of the therapeutic movements and exercise. And the biggest thing is spinal manipulation. That's what we're trained in. That's our main modality we use. Combined, these treatments are more effective than individually. So, if you just go to physical therapy or massage therapy or exercise therapy, and none of those working individually, but we put them all together and we seem to get a better result. So wrapping your head around it, we don't have to put our jokes in. Board-certified chiropractic sports practitioners have advanced training and evaluation treatment of sports injuries, including concussions. Incorporating these tests and shows our documentation that the patient does have a problem, because a lot of times you have an engineer who works at NASA who isn't able to do their job because they had a concussion 4 weeks ago, but they should be over it, right? You should be over it, but they're not. So this helps us actually document they do have a problem so that they can get the help they do need in the understanding at work or at sport to take a break. And then understanding how to monitor their own symptoms is helpful for the patient. With these same tests, they can do at home and see where they are, which helps them recover quicker.